Hi everyone, welcome to researchmd.com. We got another great presentation today. Today we're going to teach you all about primary biliary cirrhosis, okay? Thanks for joining us. So let's talk about first of all, we talk about the definition of primary biliary cirrhosis, okay? It's a chronic progressive liver disease. It's an autoimmune. The one thing you need to remember is an autoimmune diseases, right? Any autoimmune diseases, that means if you're positive one autoimmune, there's always there's other autoimmune diseases with it. And the word you have to characterize by destruction of interlobular bile duct. Remember, interlobular bile duct, chronic autoimmune. Okay, remember that. So we got a nice picture over here. The main differentiating fact is, the extrahepatic or common bile duct, this area is not affected. Remember that. Okay, so I'm just going to put, this is what's very important. This is mainly this interlobular duct and subdural duct. Okay, so below this is not affected. Remember, okay, common bile duct and large one. So that's why when you do an imaging studies, you will not find anything. Every got that? Now, let's look at the epidemiology. What's the most important thing in epidemiology? Females, okay, 10 to 1. I don't know if any other disease is like such a huge predominantly in females. So if I'm writing an examination question, if I say, a 40-year-old female with pruritus, then always kind of think about primary biliary cirrhosis. I would do. Very, very important. Otherwise, if you look at it's still a rare disease. Like I think the prevalence kind of run where anywhere 1 to 40 per like 100,000. Okay, remember that etiology. So what is it like? Genetic factors play a big important role in this. You have a family member, immediate family member, most likely would get it. And the other environmental causes like bacteria has a role, like E. coli. Some studies have shown E. coli and mycobacterium also have like a couple of this organism associated with it, right? What are the other things? Nail polish, hair dye, and smoking. So if I'm writing a question, this is like a very, very important, right? I mean, somebody, say like a 50-year-old patient who work as like, or just working in the nail polish business or something like that, and then come with itching, and then we have to think about female, think about primary biliary cirrhosis kind of thing, okay? So when we did that, what are the clinical presentation? The clinical presentation, number one clinical presentation is fatigue. That's the most common. It's like really tired, okay? The second one is pruritus, okay? Number 3, xanthoma, where it's from like hyperlipidemia and all that too. And the other one you have to think about like varices, okay? So
is it like varices are early findings or late findings?
Very good question. A lot of people think, but studies have shown like when they did the study, they found varices usually the initial kind of presentation also. Okay, it's not, a patient doesn't have to have cirrhosis and then have varices. That's what we just kind of put it there.
Okay.
Okay, so varices, it could be an early presentation also, remember that. So we know the presentation, and then we come up here and let's look at the pathophysiology, right? That's the next thing we just kind of talk about. When you look at the pathophysiology, we talk about this environmental agent like E. coli, got nail polish, hair dye, and all of those kind of things, right? You play the molecular mimicry mechanism presented by antigen presenting cells and to activation of B cells and T cells. The main thing, activation of B cells and T cells. Let's look at the B cell activation. That plasma cell, then you got antibodies, and what is this called? Anti-mitochondrial antibody, right? That's very, very important for this. So anti-mitochondrial antibody, that's like one of the diagnostic tests we do diagnosis, right? And then what happened on the other side? We just talk about the B cell on this. Plasma cells and antibodies help us in diagnosis. On the other side, this is where most of the damage is coming from this side, right? You got the T cells, CD4, CD8 cells activated. We got the perforin, granzymes, damage, they cause apoptosis, destruction, and intraepithelial cell, there's leakage of bile, okay, and when you bile leak into the interstitium, that's what the main complaint of pruritus comes in, okay? So if you look at it, our presentation, clinical presentation, number 2 is like pruritus. So if there's fatigue and pruritus and all of this, you can probably, you can say like the diagnosis pretty much will come back to that. Now, what happens when the damage continues to occur, right? There's chronic inflammation, fibrosis, cirrhosis, and all those kind of things. Late, like liver failures picture emerges, okay? But these are in the late stages also, remember. We need to catch these people in the early stages. So what investigations would you do? So if somebody come with alkaline phosphatase, right? You got an isolated, everything else normal, you got an isolated alkaline phosphatase. What's the first thing we do?
GGT.
Yeah, it's just, what is the term I'm looking for? You fractionate it, right?
Okay.
You do any GGT to make sure, what are the main three places alkaline phosphatase can come from?
Liver,
Liver,
bone,
bones,
Placenta.
placenta. Three places, that's the only main three places kind of thing too. So we need to differentiate what's going on, right? So we need to make sure, so you do fractionated, then you do GGT. In this people, GGT is going to be elevated, right? And the next one is the most important, is the anti-mitochondrial antibody. Okay, the sensitivity about this, I'm just going to write, sensitivity is around 94%. Specificity is around 95%, okay? So very good test, anti-mitochondrial antibody, right? Excellent test, can remember that. Now, what is the role? Is there a role for imaging? Like, what are we looking for? Should we get an ultrasound?
no.
Because we're not going to find anything, right? You look in the common bile duct, those kind of things, you will not find it. So there's no role for imaging. Only thing you do imaging is that rule out other causes. Let's say, like, primary sclerosing cholangitis, right? There's common bile duct, you got the bead-like pattern and all that too. Okay, so that is like, if you want to rule out other causes, that's what MRCP and all of that have like a role in it. Next thing is the treatment. How do you treat it?
UDCA.
UDCA, remember that. That has shown improve the survival. The more earlier you start, less damage, and patient, you could prolong the, time for the liver transplantation. The disease progress, then you have only options like a liver transplant to increase to decrease the mortality. And the symptom wise, how do you treat it? We already said pruritus, right? Pruritus, cholestyramine have a role in it. Rifampin also you can use to symptomatic treatment. It doesn't affect the mortality, or this is only for symptoms treatment, okay? And then what are the complications you can develop? Number one, you can have like osteoporosis because vitamin D deficiency, because all the intestinal absorption of like vitamin A, D, E, K, and all of those kind of affected. So osteoporosis is very common. Number two, we already hyperlipidemia is like number one. We already talked about the presentation xanthoma, right? And then you got portal hypertension. We already talked about varices, early presentation, and remember hepatocellular carcinoma. You have to be very careful, okay? This is like, late presentations could be. So what are the things when you do, when somebody, that is why. So what kind of things you have to do, like a screening, right? So in this patient, every 6 to 12 months, you should do screening for abdomen. You could do an ultrasound or imaging and check the serum alpha fetoprotein, okay? And then make sure you do the vaccination in these people for hepatitis A and B. Okay, thank you so much for watching. We'll be back with another presentation soon.